After studying this module, you shall be able to know more about clinical interview and its goals, learn the different types of clinical interviews, to identify the stages of interview, to evaluate its strengths and weaknesses, and also to analyze the skills and communication strategies implemented in clinical interview. Introduction. An interview represents a verbal and non-verbal dialogue between two participants whose behaviors affect each other's style of communication, resulting in specific patterns of interaction. In the interview, one participant who labels himself or herself as an interviewer attempts to achieve specific goals, while the other participant generally assumes the role of answering the questions. According to Flanagan and Flanagan, an adequate definition of clinical interviewing should be including the following factors. 1. A professional relationship between interviewer and client. 2. A client is motivated, at least to some degree, to accomplish something by meeting with the interviewer. 3rd, the interviewer and client work together to some extent to establish and achieve mutually agreeable goals for the client. 4. In the context of professional relationship, the interviewer and client interact both verbally and non-verbally, as the interviewer applies a variety of active listening skills and psychological techniques to evaluate, understand, and help the client to achieve his or her goals. 5. The quality and quantity of interaction between the interviewer and the client are influenced by many factors, including interviewer and client personality style, attitude, mutually agreed on goals. The goals of clinical interview, which are as follows: to build rapport, to collect data about patients' current difficulties, past psychiatric history and medical history, as well as relevant developmental, interpersonal and social history. Diagnose the mental health issues, to understand the patient's personality structure, the use of defense mechanisms and coping strategies, to improve the patient's insight, to create a foundation for a therapeutic alliance, and to foster healing. Clinical interview situations. Intake. The most common type of clinical interview is when a client comes to the clinician because of some problem in living. The psychologist may have little information about the client, so intake interviews are designed mainly to establish the nature of problem. Information gathered in the situation may be used by the interviewers to decide whether they are an appropriate source of help for the client, or they should refer the client to another professional or agency for alternative services. The intake interview is often critically important to successful treatment because half the clients who attend intake interview fail to return for the treatment. Next situation is problem identification, where intake interviews are also aimed at problem identification in clinical situations where a decision to work with the client has already been made. An interview may focus entirely on identification or elaboration of the client's problems. Less psychiatrically oriented clinicians and those not required to classify people may use problem identification interviews to develop description of clients and the environmental context in which their behaviors occur. This type of interview is sometimes known as psychiatric interview. According to CRC 1984, the purpose of psychiatric interviews are to arrive at a diagnosis formulation and a rational treatment plan. An attempt is made to discover the origin and evolution of the patient's mental disorders by obtaining the biographical historical account that can provide a psychological portrait of the patient. Many psychiatric interviews contain a mental status examination. Next situation for clinical interview is orientation. To make the experience of receiving psychological assessment or treatment less mysterious and more comfortable, many clinicians conduct special interviews to acquaint the client with the assessment, treatment, or research procedures to come. Orientation interviews are beneficial in at least two ways. First, because the client is encouraged to ask questions and make comments, misconceptions that might obstruct subsequent sessions can be discussed and corrected. Second, orientation interviews also can communicate new expectations designed to facilitate later interactions. Often, this can be done by describing the kinds of things that good clients are expected to do in assessment or treatment. Next situation in clinical interview is termination. An interview, or at least a portion of it, is designed to explain the procedures and protections involved in transmission of privileged information and to provide a summary and interpretation of assessment results can help alleviate the distress that clients feel about the assessment. In research settings, a termination interview is referred to as debriefing. Debriefing includes an explanation of project in which the subject has participated and discussion of the procedures employed in it. Completion of treatment also requires some form of termination interview. Many loose ends need to be tied up. There is gratitude to be expressed and accepted, reminders to be given about the handling of the future problems, plans to be made for follow-up, contacts, and reassurance given to the client about their ability to go it alone. Termination interviews serve the purpose of making the transition from treatment to post-treatment as smooth and productive as possible. Then we have next situation, which is crisis interview. In the cases when a person's problem are of an immediate and pressing nature, the interviewer does not have the luxury of scheduling a series of assessment sessions followed by treatment. When interviewing a client in crisis, the clinician tries to provide reassurance, assess a problem, and explore the potential resources, all the while projecting a calm and confident manner. The goal of the crisis interview is to resolve the problem immediately at hand so that a catastrophic outcome, which may be suicide, is avoided. For some individuals, 1 or 2 interviews with the skilled clinicians will resolve the crisis and they are able to resume to their lives without further need for mental health services. While for others, crisis interview is first step towards developing permanent solution to long-standing problems. Next situation we have is observation. Interviews provide an opportunity to observe the client's behavior. Clinicians sometimes conduct interviews to see how a person deals with certain circumstances. Here, the interview provides a context for observing the interviewer's reaction to stressful, ambiguous, or conflict-laden situations. Now we have certain common types of interviews. Intake interview. When a client seeks psychotherapy, the main goals of the first interview are to define the problems to be worked on, therapy, and establish the goals of treatment. The kinds of questions the therapist might ask include: what is the main problem for which the client is seeking help? What are the client's expectations? From cognitive behavioral perspective, Canfer and Sheft in 1988 suggested 6 think rules to guide clinicians, helping clients to define their problems. First rule is think behavior, which means to set the stage for change, the clinician and the client define the problem and possible solutions in terms of actions. 2. Think solutions. Both therapist and the clients tend to focus upon problems, asking the clients to think about how a problem situation might be handled differently provides valuable information about the appropriate targets for treatment and possible therapeutic strategies. Number 3, think positive. What are the client's strengths? What resources does she or he have to overcome the problem? Number 4, think small steps. When establishing goals for therapy, the therapist should help the client think in increments. Number 5, think flexible. Therapy can be viewed as a series of trial and error experiments in which the therapist and clients experiment with the potential solutions. Number 6, think future. In defining the goals and strategies for therapy, the therapist helps the client keep an eye on the future. Next type of interview we have is case history interview. The case history, sometimes called the psychosocial history, is a detailed description of the client's background. The history provides information that may be necessary to formulate a complete diagnosis. Knowing a person's history also helps the clinician to understand how the presenting problem fit in the broader context of the person's life. Typical information gathered in a case history interview might include: number 1, birth and development. Were there any complications in pregnancy or during birth? Did the client achieve developmental milestones at the normal age? Number 2, family of origin, who raised the client, did the family remain intact, how were the client's relationships with parents, siblings, extended family, did any family member experience mental health issues, substance abuse, significant medical or legal problems, education, till which standard did the client go to school, did he or she repeat any grade, received any special education services, were there any significant behavioral problems in school, etc. Next problem we may gather in case history taking may be regarding employment, recreation or leisure, sexual history, dating and marital history, alcohol and drugs, physical health, etc. Next we have diagnostic interview. The goal of a diagnostic interview is classification of the client and his or her problems. The assumptions underlying diagnostic interviewing is that psychiatric disorders make themselves apparent through set of signs or symptoms. The client's complaints or dysfunctions are classified according to diagnostic system like DSM or ICD-10. In the diagnostic interview, the clinicians observe the client's behavior, inquire about his or her symptoms in detail, and gather relevant personal and family history. In addition to inquiring about the criteria for specific mental disorders, the interviewer also gathers information about the stable personality characteristics, general medical conditions, life stressors, and general ability to function. Unstructured clinical interviews are probably the most popular method of arriving at a diagnosis. In an unstructured clinical interview, the clinician develops hypotheses about the client and his or her symptoms over the course of assessment. Othmer and Othmer in 1994 proposed the following 5 steps in diagnostic interviewing. Number 1, diagnostic clues, which basically means the client's chief complaints, behavior, history, and presentation. Based on these clues, the clinician will create a list of possible psychiatric disorders, excluded disorders, and unexplored disorders. In this step of the interview, the clinician tends to ask open-ended questions such as what brought you here, or tell me what is troubling you. Next is diagnostic criteria. The clinician inquires about the specific diagnostic criteria. For example, have you ever heard voices or seen things which others cannot see or hear, etc. Then we come to psychiatric history. In addition to the previous clues, the clinician also gathers information about the pre-morbid functioning and the family history. Diagnosis, which is a 4th step, and that means to arrive at a diagnosis. This is where the clinician condenses the various data into a handful of diagnostic labels and ratings. Next step is prognosis. This is the last step to arrive at, based upon the 5 diagnostic axes as well as ancillary information gathered during the interview. The clinician estimates the likely future course of the disorder and its treatment results. Next we have mental status examination. Usually described as a type of interview, the mental status examination is really a protocol for organizing one's observations of the client. The exam usually takes place throughout the interview, but the clinician may need to ask specific kinds of questions in order to gather information about certain phenomena. The topic areas typically covered in mental status examination might include the general appearance and behavior, speech and thought, consciousness, perception, obsessions and compulsions, orientation, memory, attention and concentration, general information, intelligence, insight and judgment, and higher cognitive functioning. Now we must also discuss the structure of interview. Number 1, non-directive interviews. At one end of the structure continuum are non-directive interviews in which the clinician does as little as possible to interfere with the natural flow of the client's speech and choices of topics. Then we have structured interviews. At the other end are structured interviews, which involve specific set of questions presented in a particular order. In addition, there is usually a carefully specified set of the rules probing so that, as in a structured test, all interviews are handled in the same manner. Structured interviews lend themselves to scoring procedures from which norms can be developed and applied. Mental status examination is a good example of structured clinical interview. Next we have semi-structured interviews. In between are many blends referred to as guided or semi-structured interviews. These interviews combine organization with flexibility and require the interviewer to exercise well-tuned listening skills and discretion in guiding the interview. Semi-structured interviews follow a specific outline of the topics, provide explicit rule for the interviewer to follow, and also to require the interviewer to make independent decisions about the wording of the questions and interpretation of the answers. Majority of the clinicians adjust structure to accommodate the goals of the interview. Structure also depends on the theoretical orientation and personal preferences of the interviewer. In general, phenomenological clinicians provide the least structure. Freudians usually provide more. Behavioral clinicians are likely to be most verbally active and directive. The major advantage of structured interviews are increased reliability of the data obtained and the possibility of training non-professionals to conduct structured interviews or of designing computerized version of the interviews. One possible problem is that structured interview depends too heavily on the memory and descriptive abilities of respondents. Therefore, the validity of the reports might be questionable because of the problems with the respondents' understanding of the question, motivation to answer truthfully, or ability to self-monitor. Now we must discuss the stages of interview. The first stage is the opening. Under opening, we have several sub-stages which may include initial observations, establishing rapport, the interviewer's opening statements, the client's opening response, interviewer's response to the patient's story, reducing the client's anxiety. So next step after the opening stage we have is the body. The body of the interview is concerned with gathering the information necessary for at least a tentative formulation of the patient's problem and character. In general, the clinician seeks to learn what are the patient's current complaints and symptoms. Were there recent stressful events that might have dislocated adaptive mechanisms and led to the present crisis? What kind of person he or she is? So, what are the talents, strengths, competencies, as well as the personality defects? The next substage under the body of interview stages, look for the past events. Fourth is pursuing themes. Fifth is sources of clinicians' judgment, making inferences. After that, the last stage we have is the closing stage. Before the interview is ended, there is a need to restore the patient's calm, give him information and plan with him the next step. So this stage may include several sub-stages which include restoring the client's composure, summarizing the crucial themes and issues, providing information, clinicians thinking back. After discussing the stages of interview, we must also note the communication strategies which are the prerequisite for any successful interview. So the communication strategies that we are going to discuss here are: number one, verbal strategies. The clinicians may use different types of questions to elicit information from the client. They might use open-ended questions or at other times closed questions. As interview progresses, however, the clinician is interested in gathering more specific information. So 3 examples of appropriate closed questions might be: of all questions we discussed, which bother you the most, etc. Next communication strategy is non-verbal strategies. Much of what gets communicated in an interview occurs non-verbally. It has been estimated, for example, that 65% meaning of the message is gleaned from the non-verbal behavior. Skilled clinician reads a client's non-verbal behavior for clues about the client's emotions. Clinicians need to take into consideration the client's cultural background when developing hypotheses based on the client's non-verbal behavior. In some cultures, for example, averting one's eyes is a signal of respect. Skills required for interviewing. Number 1, questioning. 3 specific kinds of questions useful in interviewing include clarifying questions, open-ended questions, and close-ended questions. Next interviewing skill is transitional phrase. Interviewers should be using minimum effort to maintain the flow, such as using transitional phrases, for example, yes, and, I see. Next skill is verbatim playback. In verbatim playback, the interviewer simply repeats the interviewer's last response. Another skill is paraphrasing and restatement. A paraphrase tends to be more similar to the interviewer's response than restatement. Both communicate that interviewer is listening and make it easy for the patient to elaborate upon. Summarizing and clarification statements. The summarizing communicates that the interviewer has a good idea of what the interviewee is trying to communicate, and clarification shows yet further comprehension. Empathy and understanding. This is a more powerful response. This response communicates that the interviewer understands how the interviewee feels. Understanding responses that stay close to the content and underlying feeling provided by the interviewees permit them to explore the situation more and more fully. Now we must know what are the reliability and validity of any interviewing procedure. The interview reliability is estimated by some writers by looking at the degree to which different judges agree on the inference drawn from the conversation with the same client. An alternative approach is to ask about the reliability interview data themselves. One would expect the client's responses to be similar from one interview situation to the next or from one interviewer to the next. But there is surprisingly little research on this point. The available data comes mainly from survey research and indicate that when innocuous information is requested or when interview intervals are short, reliability is also generally quite high, with many of the structured interviews and with mental status interviews repeated over a short period of time. The degree to which the information obtained from the interviewee is accurate is validity in an interview. Interview data can be accurate in absolute terms in comparison to other assessment tools. It may be the best source of clinical information. In a study cited by Thorne in 1972, answers to the question. Clients may also misremember or purposefully distort various types of information. The probability of distortion is increased when the information shot is of an emotionally charged or sensitive in nature. A person's emotional state may also affect his or her interview responses. The desire to present oneself in a particular light to a mental health professional has been called impression management, and it can lead to invalid interview data. Situational factors of various kinds may also affect the validity of interview data. Now we will discuss the strength and weaknesses of interview method. As a method of assessment, interviews are fallible and subjected to bias from various sources. There is simple evidence that interviewers can intentionally or otherwise bias information given to them by social research interviewing. What respondent report is a function of age, sex, and other social characteristics of the interviewer, the relationship he establishes and the personal qualities, as well as the topics he inquires into the particular question he asks. Compared to any other instrument, interview is an instrument of great flexibility and breadth. It can potentially cover the greater range of information, and as individually relevant themes emerge, the course of inquiring can be redirected and refocused. Language and question form can accommodate to the patient's communication style. So too the pace, intensity, and duration of the transaction to his emotional needs. The very strengths of the interviews are also the weaknesses. When considered as a method of psychological assessment, flexibility and breadth allow unreliable information and biases. Now we come to the summary of this chapter. The interview remains the most basic, most commonly used and most powerful technique in clinical assessment. Through training and practice, the interviewers can function more effectively. For some purposes, greater standardization can make the interview a sharper and more dependable tool. In the interview, the clinician is at one time stimulus to the situation of interview, observer of, and interpreter of the patient's state.